I am Dr. Ranajit Chatterjee, and today I am going to discuss with you with the various aspects of acute kidney injury. The acute kidney injury is a nascent terminology. It is the term that has evolved in this century, whereas it has been termed in different ways through decades and through centuries. In 1802, it was called Ischemia renalis by William Himberden. Till 100 years after that, it went on in the name of Ischemia renalis. After that, William Osler's textbook started mentioning it as acute Bright's disease. By the time the First World War came, a lot of soldiers were dying of dehydration, and from their dehydration, they were developing acute kidney injuries, and it started named as war nephritis. And by 1951, the first terminology by Dr. Smith in his book of nephrology, it came out to be acute renal failure. So from 1951 onwards, for another 50, 60 years, it was known as acute renal failure. Now the new terminology has come up that is known as acute kidney injury. Now, let us define acute kidney injury first. And before defining, I'll show you a case how the kidney injury is evolving. For example, a 40-year-old man, 65 kgs of weight, he presented in the casualty with 5 days history of fever, cough, expectoration, respiratory distress. And 2 days back, his wife noticed him that he's a bit confused. His blood pressure was normal, his respiratory rate was quite high. He was basically going towards pneumonitis. Along with that, he was developing ARDS. The PO to FiO2 ratio was decreasing. Creatinine here was 0.8, and the urine output was less, 300 ml per 6 hours, and 1200 ml at 24 hours. Now see here, the criteria is 300 ml over 6 hours. The urine output has significantly come down. And by 48 hours, the creatinine has started rising. From 0.8, it has come to 1.3, rise by 0.5. And by 72 hours, it is again around 1.5, and the urine output further came down to 250 ml. And by the fourth day, it is 1.6, and urine output is 150 ml over 6 hours. Now, the point is, at what stage I'll say that this is a case of acute kidney injury, when I should be concerned. So, if you see the definition that has been given by KDIGO, and we are following this definition now, acute kidney injury is defined as any of the following: increase in serum creatinine by 0.3 milligram per day within 48 hours. That is, that small rise of serum creatinine is very significant, and that too within 48 hours. Or if the creatinine is gradually rising 1.5 times the baseline over the first 7 days, and the urine volume has come down below 0.5 ml per kg per hour for 6 hours. So, a patient, when the urine volume is coming down within the first 6 hours, that is also very significant. So this is basically the definition. Wherever it fits, it stands as acute kidney injury. But the definition is up to 7 days. So up to 7 days, we are saying that this compromised renal function is acute kidney injury. If I go for the staging of this, all this started in 2004 when the rifle criteria came up, and the rifle criteria started defining it into risk, injury, failure, loss, and end-stage renal disease. It took 3 criteria: serum creatinine, glomerular filtration rate, and urine output. Now, once the serum creatinine is rising by 1.5 times the baseline, or the glomerular output GFR has decreased more than 25%, or the urine output has less than 0.5 ml per kg per hour over 6 hours. So this was the risk. Now, the GFR decreasing further by 50%, or the increase in creatinine is rising more than 2 times the baseline, and the urine output is persistently decreased over 12 hours over 0.5 ml per kg per hour, that is injury. And failure, obviously the serum creatinine is rising further by 3 times the baseline, GFR by more than 75%, or the serum creatinine gone beyond 4 milligram per 100 ml. That is important. And there is an acute rise by 0.5 milligram per 100 ml. This is also very important, but this 0.5 milligram per dl rise, acute rise, they have mentioned in the failure stage. And the urine output further decreasing either to anuria or to further decreasing to 0.3 ml per kg per hour for another prolonged period of 24 hours. They took two stages, loss and end-stage renal disease, where loss is basically complete loss of renal function, and end-stage renal disease, obviously, when the patient needs dialytic support. So this was there that came in 2004, but it was modified further by the AKI criteria, because there are a lot of the problems which was found with the rifle criteria. Though it was basically it was allowing the identification of significant proportion of AKI patients, especially who were hospitalized, and it also was enabling the AKI severity, but it didn't basically aim at therapeutic interventions or any adverse outcomes. So for that, the AKI criteria came, and the AKI criteria basically, here a small change by 0.3 milligram per dl was taken as one of the criteria that was added to it over the 48 hours. And this 48-hour criteria came with AKI, and the rest more or less was the same, and they took out the last two stages and the GFR from their classification. KDIGO was quite smart. By 2012, they combined the AKI and the rifle, and they came out with the criteria and definitely with this diagnostic definition of AKI, which we have already discussed. So where there is a progressive rise in serum creatinine or a progressive decrease in urine output, you can see that KDIGO basically has added the GFR only in the stage 3, with the exception in children less than 18 years of age, where they have told about the acute decrease in eGFR of less than 35 ml per minute is one of the criteria of stage 3 SI that KDIGO has used. Now, if I simultaneously vis-a-vis compare these three criteria, it was compared and it was found that KDIGO is superior to rifle in diagnosing AKI. KDIGO had a higher incidence of AKI than both of rifle and AKI, and it also helped in evaluating the hospital mortality, more predictive than rifle, but not that of AKI. And KDIGO has had a superior prognostic ability. So in 2012, the classification that came and the gradation that came of KDIGO is now still followed by us. And it has been further tried to be modified. I'll come to that, how it has been done. Now remember that acute kidney injury is still up to 7 days. Moment you cross 7 days and up to 3 months, this stage is known as acute kidney disease. And beyond 3 months, when you have some structural changes also coming up in the kidneys, this is known as chronic kidney disease. So I'm not going to discuss acute kidney disease or chronic kidney disease here. I'll restrict myself to acute kidney injury. Now, there are a lot of pitfalls in the definitions of AKI. We all know nowadays that by the time creatinine rises, around half of the kidneys have stopped functioning. So creatinine itself is not a very good biomarker for acute kidney injury. It is also basically being influenced by many situations. By suppose the administration of drugs which interfere with the tubular secretion of creatinine, which might lead to misdiagnosis of AKI. Then we reduce production of creatinine. Obesity sometimes overdiagnoses AKI. So there are many situations like this. For example, fluid resuscitation overload may lead to delayed diagnosis of AKI. There may be progressive CKD with gradual rise in serum creatinine. This leads to misdiagnosis of AKI. There are certain things called pseudo-AKI, where you have extrinsic creatinine administration as a buffer in medications like dexamethasone. So these type of things also raise to certain suspicion about the usefulness of serum creatinine as a very good diagnostic marker, as a biomarker for acute kidney injury. So the concepts of biomarkers started coming up. So if creatinine is not good, sometimes you have high output renal failure and urine output is more. So urine output is not good. So what exactly should be our marker that will say that yes, this is the stage when we are having acute kidney injury? For the cardiologists, they are much better in positions. For example, you are having an acute coronary syndrome, you have the troponin I's, the troponin T's, but what about the kidneys? So different biomarkers started coming up. There may be markers of glomerular function, there may be markers of inflammation and repair, markers of tubular damage. So a lot of markers started coming up, and different markers were basically telling about the dysfunction of different part of the kidneys. For example, decreased glomerular function was better seen by cystatin C, decreased tubular function by fractional excretion of sodium or the fusamide stress test. Upregulated proteins were basically marked by KIM1 and definitely by the latest one, that is the Nephrology. I'll come to that. And there are different other markers also. So these markers, if we see, the most common of them, which was used mostly by the clinicians, was cystatin C and the NGAL. NGAL is neutrophil gelatinous associated lipocanin. It is a 25 kDa glycoprotein. It is produced not only by the neutrophils but also by the renal tubular cells. And basically, these are released into the urine during tubular damage. Similarly, cystatin C is a 13 kDa cysteine protease inhibitor. And these basically are freely filtered in the glomeruli and completely absorbed and catabolized by the proximal tubular cells. So there is no tubular resorption or secretion. So these markers, if they're increased in the urine or sometimes in the serum, they're indicators of acute kidney injury. But the best one that has been discovered till date is the cell cycle arrest markers. That is, even before the damage, when the cell is in stress, these markers will be increased. And they are basically IGF-BP7 and TIMP2. IGF-BP7 is insulin-like growth factor binding protein 7 and a tissue betanoproteinase 2. If the product of this is increased in the urine, then you might say that my patient is moving towards acute kidney injury. That is, even before the acute kidney injury is manifested, even before the serum creatinine is rising, even before the urine output is decreasing, if this marker is increased, so that means your patient might be moving towards acute kidney injury. So these are the cell cycle arrest in response to cell stress, and the markers are increased. Lot of studies have come up, mainly in the surgical patients. They have been found to be quite effective, and the markers, they've given a value. Anything more than 0.3 in the urine is positive, considered to be positive, and the patient could develop AKI moderate to severe within 12 hours of the testing. And below that, AKI may not develop. It doesn't mean that it will not develop. It may not develop. So, and studies on NGAL has also been done. It has been found that NGAL is quite a good marker in its cutoff concentrations, which is either found in the urine or plasma. And NGAL is also available in our market freely. So NGAL can also be further studied to see its effectiveness in diagnosing acute kidney injury. So on the basis of this, something came out in the mind of Marilyn Westerman. She started thinking, why not we can divide these stages into one stage where the kidney function is still there, that is, the damage is not being predicted by the serum creatinine or the urine output, but the biomarkers are increased. So they give the staging as 1S, where the biomarker is positive, but other everything is normal. Now, he told that when the biomarker is negative, she was thinking about that whether if the biomarker is negative and the serum creatinine is rising or the urine output has decreased. So that is the stage, it is 1A. And if the biomarker is positive and both the creatinine is rising and the urine output is decreasing, so that is the stage of 1B. In this way, he divided into 2A and 2B, 3A and 3B. But she was not sure that which biomarker to be used. Still today, we are not sure that which biomarker to be used. So what we can do basically, before going into the further details of that, we can come to the further diagnostic evaluation of AKI. So in that AKI, that age-old definition of pre-renal, intrarenal, and post-renal should not be forgotten. Old is always gold. So remember the pre-renal part. The best way of marking it is the fractional excretion of sodium. Very easy to do it. You have to send the sodium, you send the urine sample for the urinary sodium and the urinary creatinine, and the serum sample simultaneously for the serum creatinine and the serum sodium. So urinary sodium divided by serum sodium divided by urinary creatinine by serum creatinine into 100. That is basically fractional excretion of sodium. And if it is less than 1%, this patient is in a pre-renal failure. Remember, this will not hold good in those patients who have already received diuretics. In a patient who have already received diuretics, fractional excretion of sodium will not hold good. There you have to see the fractional excretion of urea, where it should be less than 35%, then it is pre-renal. Around higher it is going up more than 50% and above, it is either renal or obviously in the post-renal we don't measure it because post-renal can easily be diagnosed with either by ultrasound, by a CT scan. You can see some obstruction, you can see some kinking, you can very well understand this is a case of post-renal uh, acute kidney injury. Similarly, these tests may be followed very easily by the bedside and still now followed by many nephrologists and intensivists in their ICU. So once your patient comes to you, you forget everything. Your patient's urine output is coming down, your creatinine is going up. Just send a urine sample. Go for a centrifuged urine sample and see what type of cells you are getting there. If you're getting a hyaline cast, you don't have so much of significance. But if we are getting there some tubular casts, so their renal tubular cast marks you acute tubular necrosis. You're getting the eosinophilic cast, the white blood cell cast, they're allergic nephritis, interstitial nephritis. Or you are getting some red blood cell cast, it may be glomerulonephritis. And then further, you have to go on either rule out multiple myeloma by seeing the serum in the urine immunoelectrophoresis, or you can go for certain kidney biopsies to rule out what exactly type of glomerulonephritis you are having. So it's a very easy way of diagnosing. The diagnostic chain is not so very difficult. You have to have renal ultrasonography to it. You have a normal kidneys, you have a hydronephrosis, you have a bilateral small kidneys. It is chronic renal failure. Hydronephrosis, definitely there is some obstruction. Normal size kidneys, where you have to suspect there is a renal parenchymal disease, just go for a urine analysis and they will say you exactly what is your situation. Similarly, your patient's volume status that we regularly measure in the intensive care can tell you whether your patient is volume depleted or not. That is, they're going more towards pre-renal disease. Remember, not only a volume depletion, a volume overload can also cause pre-renal disease. So both of them, there is depletion and overload, are the causes of pre-renal acute renal failure or the acute kidney injury. So how to assess the severity of the AKI by the bedside? When you come for the rounds, how do you assess? You don't, if you have the serum creatinine, if you have the urine output, it's fine. But still, how do you assess whether it will progress further or not? You don't have the TIMP2 or IGFBP7 in all the ICUs. It is known as Nephrology in the market. It's quite costly nowadays. Still not available in all the ICUs. So just do a furosemide stress test. Here, if the patient is euvolemic or hypervolemic AKI, remember this, euvolemic or hypervolemic AKI in stage 1 or stage 2, if you give furosemide 1 milligram per kg to those patients who have never received furosemide, or 1.5 milligram per kg to those who have previously received furosemide, and observe the urine output over 2 hours. If it is less than 200 ml, that means your patient is moving towards acute kidney injury stage 3, which may be AKI 3 or KDIGO 3. And if you can combine these two with certain biomarkers, the diagnostic predictability obviously improves. The furosemide stress test by the bedside is one of the very good predictive indicators whether your patient is moving towards acute kidney injury or not. Similarly, the renal angina index. In the renal angina index, where what we do is see the level of the serum creatinine, how it is going up, and we give a score. And along with that, we give a score to the patient's condition. We multiply these two scores, and if this is going beyond 6, then your patient is definitely will move towards acute persistent severe AKI maybe within the next 1 week. And if you can again add certain biomarkers like renal angina index and with LFABP, and it has been found that there is improved prediction of the severity of the acute kidney injury. Similarly, a persistent AKI risk index, the same way the scoring, the serum creatinine, and the condition of the patient, there are different types of scorings here. But this index, the PUDI index or the persistent AKI risk index, here the negative predictive value is very high, 93.9%. So you choose any one of these according to the situation in your ICU. You make it diagnose, validate it in your ICU, and then start practicing it. That will help you a lot in finding exactly during the bedside rounds whether this patient I may be ready for all those we have to do for a patient of acute kidney injury. Maybe I have to be ready for the CRRT, to be performing of the RRT different from SLED or hemodialysis. We have to be ready for that. So this is one of the ways how we can diagnose this. Now we have certain risk prediction scores, one of the best ones given by Dr. Malhotra, and you can risk factors are there, certain scoring system has been given, and a cutoff value of more than 5 points has a very good positive predictive value is not so good, but the negative predictive value is around 95%. So we can go for some renal risk prediction scores, own ICU, and you have to see whether this is good for your ICU or not, and you can use this by the bedside. So now we have different electronic AKI alerts that are coming up. This is beyond the limit of this lecture because we have to go for a long discussion on this about the artificial intelligence. But yes, slowly it is coming up. Maybe in the next couple of years, you will find artificial intelligence taking up a big role in diagnosing acute kidney injury. So this ADQI, they gave a very good idea about the acute kidney injury. So if there is a damage without loss of function, that is known as subclinical AKI. Loss of function without damage, this is prerenal AKI. But damage with loss of function, this is the intrinsic renal failure. So we have to find out whether it is a loss of function or a damage. Both, it is intrinsic, only one without damage, prerenal. Damage without loss of function is subclinical. Very easy to say, very difficult to do. So Ronco also came up with this ABC concept, the AKI biomarker composite concept. For example, as in arterial blood gas, the pH is seen. The pH basically marks the hemostasis. The PO2, that is the transfer of oxygen. The PCO2 about the damage of the membranes in your alveolar capillary membranes. Similarly, the base excess or the base deficit about the reserve. The bicarbonate about the compensation, and the lactate about the stress. Similarly, just see, we can take these composites as the urine output coming out as the situation which can say about the overall hemostasis of the patient, whether the patient is a hypovolemic, hypotensive, what is the situation. Solute transfer can be seen by serum creatinine, whether the tubular damage markers by NGAL, the reserve, the fusimide stress test, or your compensation is done to see whether your patient is fluid overloaded or not, the percentage of fluid overload. And the best one is the system stress, like lactate, which will tell you about, yes, my patient is moving towards acute kidney injury, might be moving. Even the damage has not yet been done. The kidneys are already in stress. I have to combine all these things. We have to combine this. Slowly we are coming up. Definitely in the next 2-3 years, you'll find something where you'll find a composite way of diagnosing AKI much earlier than what we are doing today. So how do we prevent AKI? The prevention is always better than cure. In fact, inside the prevention itself, the cure is there. So this KDIGO, this told is way a decade back, around 2012. We all know about this. We have to discontinue all the nephrotoxic agents. We have to ensure the volume status, perfusion pressure, good hemodynamic monitoring, monitor serum creatinine and urine output, avoid hyperglycemia, consider alternatives to radiocontrast procedures, go for certain non-invasive diagnostic workups, give invasive diagnostic workup. But the most important part is that, see, the interesting part is that in stage 2, they mentioned consider acute renal replacement therapy. So the point is, there way back in 2012, they're telling to consider renal replacement therapy stage 2, but a lot of water has flown through over the Thames this in between, and After that, and you will see that how situations has changed. Definitely there will be a lecture on that, how the different studies came up, the Align trial, the AKI trial, the AKI 2 trial, the Ideal ICU trial. All these trials came up, and last the Start AKI trial, how they have changed our mindset on the started of renal replacement therapy, at what stage. I think definitely it will be discussed. And there are different components of KDIGO based postoperative AKI care. So again, they are more or less the same that what we was discussing, that you have to avoid the nephrotoxic agents, you have to maintain your the glycemic control, you have to discontinue angiotensin converting enzyme inhibitors and receptor blockers for the first 48 hours after surgery, close monitoring of creatinine and urine output, consideration of alternatives to radiocontrast agents, utilization of balanced crystalloid solutions over hyperchloremic 0.9% saline. Very bold statement. Yes, on this, the SSC 2021 has also come up, surviving sepsis guidelines. They are basically telling balanced crystalloids to be used over normal saline in the initial resuscitation, but though the quality of evidence is very poor, different studies have supported it, like the SMART trial. Different studies have opposed it, like the BASICS trial and the PLUS trial. When you go through it, you will understand, and those who have already gone through it, they will understand the pros and cons of using balanced crystalloids and hyperchloremic saline. I would have loved to speak on this, but I don't have any time. Similarly, you have to go for very good hemodynamic monitoring, keep your blood pressure within the range, and go for a good hemodynamic management, volume optimization, use vasopressors early, glycemic controls, and nephrotoxics towards it. So this was the prevention bundle given by us in ISCCM guidelines. 2021 that came up, and we have suggested to keep the mean arterial pressure more than 70 to 75 millimeter of mercury, the diastolic blood pressure more than 55, the mean perfusion pressure more than 60, and the mean arterial pressure more than 85. We have asked to start non-adrenaline, not to use dopamine. We recommend avoiding hyperglycemia beyond 180, and obviously using aminoglycosides. You have better if you have better options available, and obviously the nutrition have to be maintained well. Remember, in pure AKI where there is no pre-existing kidney disease, you don't have to restrict your proteins. You may go up to 1.7 gram per kg per day if the patient is already on renal replacement therapy. So don't restrict on proteins in those who have just developed AKI, and give a energy of around 25 to 30 kilocalories per kg per day. So these are the recommendation. And the initial care bundle, again, both is the assessment and the fluid resuscitation. These are the most two important things that you have to see, whether the patient is fluid hypovolemic or hypervolemic. So how important it is to do those dynamic fluid assessments in your own hospital, that is to be seen, and you have to implement it. Any one of them which you are very much proficient with, you should implement that. So some words about hepatorenal syndrome. Hepatorenal syndrome is a situation where only occurs in the presence of a cirrhosis with ascites. If the serum creatinine is rising, but there should be absence of shock, hypovolemia, and absence of nephrotoxic medications, and absence of any renal parenchymal disease. There should be no proteinuria, and you don't find any signs of nephrotic syndrome. So these are the situations where we say that this is a case of hepatorenal syndrome. There are two types, type 1 and type 2. Type 1 is very rapidly progressive, whereas type 2 is steadily rising. And here also you find the fractional excretion of sodium again is less than 1%. So it's very difficult to differentiate between hepatorenal syndrome and a prerenal acute renal failure. A patient with cirrhosis and ascites may also present with prerenal acute renal failure, acute kidney injury. So prerenal AKI and hepatorenal syndrome, how to differentiate? Because more or less everything is the same. We know that hepatorenal syndrome comes from the sympathetic nervous system overactivity, where there is renal vasoconstriction, from where you have hepatorenal syndrome. But the treatment is, we use vasopressors, terlipressin and non-adrenaline, and along with that we use a bit of volume expansion with the help of albumin. So combination of albumin and non-adrenaline or terlipressin has been found to be effective in reversing the hepatorenal syndrome. In order to separate, in order to differentiate between AKI, pre-renal AKI from hepatorenal syndrome is cirrhosis. You have to go for a very good renal ultrasound and renal Doppler to find out the resistivity index of the renal arteries. And if you find if it is less than 76%, 0.76, it is lower in volume responsive AKI, but it is quite high in hepatorenal syndrome, more than 0.8. So similarly, contrast-induced AKI, I'm not going to go into the details of this. Basically, again, the diagnosis and the definition is more or less the same. That serum creatine is rising within 40 to 72 hours by more than 50%, or by a small rise of 0.3 milligram per dl. Oligomer is precipitating. This is the situation following the contrast. Recommendation of not using oral fluids alone, and suggest of using oral lac. Basically, this was the guideline given around a decade back by Kedigo, still being followed, but there are so many studies that has come up which is showing the and doubting the usefulness of N-acetylcysteine. And not to be used is threophylline. Not to go for prophylactic intermittent hemodialysis or hemofiltration. Alternative methods have to be seen. The best way is to give good volume to the patient, volume resuscitation, and to use the lowest possible dose or isoosmolar or low osmolar hydrogenated contrast media. So this should be our idea in contrast-induced AKI. And regarding renal replacement therapy, I think definitely there will be a separate topic on this. But a small introduction. It may be continuous or intermittent. Continuous may be slow continuous ultrafiltration, continuous venovenous hemodialysis, continuous venovenous hemofiltration, or continuous venovenous hemodiafiltration. Intermittent therapies includes intermittent hemotherapy, SLED, intermittent hemodialysis, sustained low efficiency daily dialysis or SLED, or peritoneal dialysis. Basically, the concept is diffusion ultrafiltration, convection and absorption. Diffusion is basically movement from higher concentration to lower concentration against a semi-permeable membrane. Whereas ultrafiltration is movement of solutes. These are all movements of solutes. From diffusion in diffusion, it is from higher to lower concentration. From ultrafiltration is from higher pressure to lower pressure. And in the movement of the solutes from higher pressure to lower pressure, it takes out a lot of fluid. That is convection or solvent drag. So you are removing a lot of fluids along with you with convection and ultrafiltration, whereas with the diffusion, you are only removing the small molecules. And absorption is basically the molecular adherence on the surface of the membrane. So by this way, we can divide it into hemodialysis, where it works only on the principle of diffusion. Small solids are removed. That is higher concentration to lower concentration against a concentration gradient. Remember, there is a countercurrent flow of blood and the dialysate. Their flow is in opposite direction. Hemofiltration, see, we have seen the replacement solution. Because as you are taking out the extra amount of fluid from the patient, you have to replace it back to the patients also. So now how much you replace, that depends. That if you want to replace its full, it is known as a zero balanced renal replacement therapy. If you are basically replaced in partially, it is known as a negative balance. For example, your patient is fluid overloaded. You want to remove 200 ml from the patient. So you have removed 2000 ml from the patient and you give 1800 ml back to the patient. So the net deficit is around 200 ml. So in this way, we basically take out that extra fluid away from the patient. So if you want to remove only volume, you can use slow continuous ultrafiltration. For example, is congestive heart failure, or in patients suppose coming into acute cardiogenic pulmonary edema, especially the blood pressure is coming down, the blood pressure is around 60, 50, not recordable, especially in PIH patients. In this type of patients, scuff may be a lifesaver. So you cannot remove that extra fluid except with any of the drugs except slow continuous ultrafiltration. Similarly, you want to remove solutes plus volume, you can use either hemofiltration or you can do either a hemodialysis or a hemodiafiltration. But in your hypercatabolic states like sepsis, you better to use continuous venovenous hemodiafiltration. Especially renal replacement CRRT continuous forms, they are very good for hemodynamically unstable patients. They have a precise volume control, unlike the other ones. They are very effective in controlling the uremia and the hyperkalemia in these type of unstable patients. Otherwise, hemodialysis is excellent. But unstable patients, this has no alternative. Similarly, the rapid control of that metabolic acidosis in this hemodynamically unstable patients. It is very good in these patients where you have brain injuries, you have diuretic resistant pulmonary edema, you have cerebral edema, you have patients who are in acute liver failure, patients who are in AKI along with ARDS. You can just add a neonatal oxygenator along with this machine, take out that extra carbon dioxide from the patient and decrease your tidal volume to a minimum. This is known as extracorporeal CO2 removal. Definitely this will be discussed again with you. And we may have an adjuvant role in sepsis, we don't know. Already the mortality is so high that any one modality cannot differentiate whether the mortality improvement will be there or not, but still we are using in sepsis. Maybe one day we'll get a success. And some advantages in terms of renal recovery. The observational studies say there is some advantages, whereas the RCTs, there's having some contradictory results. So it is still a gray area. So this is where we stand on CRRT today. This is one of my patients done way back, a decade back, maybe 2011. Lady who came with acute kidney injury following her delivery in a private hospital. Patient came to us. This is one of the very old Pupa machines. We are not keeping it nowadays. It might be in the museum. And 7 days of CRRT was going on. Severely ARDS patients, hemodynamically unstable patients. Blood pressure was going below 50, around 50 systolic. The renal pressure was not being maintained. Slowly, the renal replacement therapy was done. All the care bundles were followed. Ultimately, she is today living happily with her children. So, thank you very much for your patient hearing, ladies and gentlemen. This is my ICU. These are my phone numbers. This is my email. Anytime you have any regarding any assistance, you can contact me. Thank you so much. This is Ranajit Chatterjee. I am really indebted to you. Thank you so much.